Alrighty. Well, it is 7:01, and I would like to start by thanking everyone for joining us. Good evening and welcome. My name is Patrick Peterson, and I work at the Basser Community Library. Basser is one of 7 libraries that are bringing you this discussion tonight. In 2019, these 7 libraries banded together to provide a single summer program entitled One Book, Many Neighbors. That summer program featured a series of discussions and programs centered on a single shared book. Throughout 2021, the libraries have rejoined together in association with the Kansas Leadership Center and the Climate and Energy Project to bring you a series of educational discussions and presentations. The first was entitled We've Been Here Before, 1918 Influenza, and was presented in partnership with the National World War I Museum in Kansas City. Our second was titled We've Been Here Before, Polio Vaccine, and was partnered with the Northeast Kansas Library System and Rotary International. Our final program tonight is called Here We Are Now, COVID-19, and with the help of experts, Dr. Lee Norman, Director of the Kansas Department of Health and Environment, Dr. Sabato Cicillo, Pulmonologist and Medical Director at Providence Medical Center, and Dr. Prashant Katrapati, Cardiologist and Medical Director at St. John Hospital. We will answer questions and discuss the latest information on the vaccine rollout in Kansas and medical concerns with the virus and the vaccine. Tonight we'll be streaming over Zoom and Facebook Live. If you have a question or need clarification on a topic, please write it in the chat, and one of our library representatives will be happy to assist you. On behalf of this partnership of libraries, including Atchison, Basser, Bonner Springs, Lansing, Leavenworth, Linwood, Tonganoxie, and Nichols, I want to thank you for attending this evening and to share with you that this program will be recorded and archived along with the others in the series for viewing at a later time. And we're happy to announce that this coming summer, the libraries will be hosting the One Book, Many Neighbors program once again. If you have the itch to dig deeper after the program tonight, the libraries have come up with a list of books available in our shared Next catalog, and that list will be shared in the chat. Now at this time, I would like to introduce our moderator for the evening, Lansing Public Information Officer, Ken Miller.
Thank you, Patrick. It's my pleasure to be a part of this discussion tonight. I am going to start by providing a little bit more of a biographical information sketch for each of our guests. We have 3. The first guest is Dr. Lee Norman. He's the Secretary of the Kansas Department of Health and Environment. He was appointed by Governor Laura Kelly. Dr. Norman received his medical degree from the University of Minnesota and did his residency in family medicine in Texas and his aerospace medicine training in the U.S. Air Force at Brooks Air Force Base in San Antonio. After serving in the Air Force as a family physician, flight surgeon, and combat medicine instructor, he practiced medicine in Seattle for 20 years, also serving as a clinical associate professor at the University of Washington School of Medicine. Norman has served as a chief medical officer for over 26 years, most recently at the University of Kansas Health System, and before that, at Swedish Health System in Seattle back in 1991. He currently is clinical assistant professor at the University of Kansas School of Medicine. In his military role, Norman is a colonel in the Kansas Army National Guard, stationed at Joint Forces Headquarters in Topeka, Kansas, reporting to the state of Kansas Adjutant General. Norman, as the state surgeon of Kansas, guides medical troop sustainment and training, health services support, force health protection, biosecurity, and serves as advisor and liaison to the Kansas Department of Emergency Management and Homeland Security. Additionally, Dr. Norman serves on the Defense Health Board as an advisor to the U.S. Secretary of Defense. We also have with us tonight Dr. Prashant Katrapati. He's the Chief Medical Officer at St. John Hospital in Leavenworth. He is board certified in internal medicine and has expertise in coronary, peripheral, and structural heart intervention. He completed fellowships in cardiovascular medicine and interventional cardiology at the University of Michigan in Ann Arbor, serving as chief fellow there. He was involved in clinical research focusing on optimal treatments for patients with heart attacks. He is a fellow of the American College of Cardiology and Society for Cardiovascular Angiography and Interventions, and has been inducted in the Gold Humanism Foundation. He sees patients in both Leavenworth and Kansas City offices. And Dr. Sabato Cicillo is the Chief Medical Officer at Providence Medical Center in Kansas City, Kansas. He is a board-certified pulmonologist with KC Pulmonary Associates, who began caring for patients in the area more than a decade ago. After having grown up in a small town in Italy and beginning his medical education in New York City, he completed his fellowship in pulmonary critical care medicine in Kansas City. He's a member of the American Society of Chest Physicians and the American Thoracic Society. Dr. Cicillo is fluent in Italian, Spanish, and English, and sees patients on the Providence Medical Center campus. So gentlemen, welcome to you all. We are going to start with Dr. Norman. I know, Dr. Norman, you have a few words that you want to say. We will then move to Dr. Katrapati, and Dr. Cicillo will also have some opening comments, and then we should get into the discussion and the questions. So Dr. Norman, go ahead.
Thank you, Ken. I appreciate the introduction. I'm a delight for me to be here, and thank you for the invitation to be on this panel, and also for these two wonderful clinicians. Because I depend on these guys. We depend on these guys, and very grateful to be here with them too. Let me start off by giving kind of an overview. In my secretary role in KDHE, I'm now in my third year. We've seen and we knew that our country was vulnerable, our world was vulnerable to have a pandemic. I did not think it was going to be a coronavirus like it was. I would have bet on it being an avian influenza, but as you say, here we are now, the title, and so let's go with that. A couple acknowledgments. One, this has not been easy. There have been many adjustments and there have been many hardships. And I am very much admiration for the resilience that our Kansas citizens and our US citizens have shown. There's been a lot of divisiveness, a lot of disagreement, but when it comes right down to it, we want to get through this. And there are some things that are going well and have gone very well, some things that still need a lot of work. And I'm going to talk just a little bit about that. One of the things that I've done, I've been a doctor for over 40 years, and I went in the military originally in '74, still in, and I've dealt both in my civilian and military roles with a fair number of emergencies and disasters, actually. And I think it's important to think about disasters. I have what I call an arc of a crisis. And when you think about a crisis, the arc that I refer to means like a tornado. You start, the tornado hits, you get through it, and it stops. A flood starts, longer period of time, but eventually the floods reside. SARS, 2003, 2004, that was also a coronavirus with an arc. Started, lasted a longer period of time. Wars are a crisis, lasted a longer period of time. HIV, a crisis, it's still a crisis, gotten a lot better. So here we are, COVID-19. There's been a start, it's peaked, and we're getting better, but we're plateauing off. So one of the questions that we all want to consider is, what will it take for the arc of this crisis to go back to pre-crisis period of time? When I called my team together at the agency 455 days ago today, as a matter of fact, and we set up what we call incident command. Incident command says something really bad's going to happen, and we want to be prepared for it. So let's get the band together. Let's get everybody together. And it's a 24/7, 365-day battle rhythm, and we're still at it 455 days later. So we've seen this very much up close and personal, much like you have. Many of you on this Zoom or Facebook Live have probably either known somebody with illness, may have known somebody with death. Where are we today? We've had as of today, 306,883 cases in the state of Kansas. That's more than 1 out of every 10 people in the state of Kansas has been diagnosed with having COVID-19. I'm sure that number is low, by the way, because a lot of people are minimally symptomatic and probably never got tested. Where are we in deaths? We're just short of 5,000 deaths. We're 4,961 deaths as of today. Now, back in the bad old days, December, January, we were having 1,000, 1,500, 2,000 cases a day. We still have about 600 cases recorded every 2 days. In other words, 300 cases a day and a few deaths every day. And we have clearly plateaued. When you stand back and you look at this, you say, how are we doing? Well, we were doing great. We were in the top 5 states in the country in hospitalizations and deaths and new case development. We're still pretty good shape, but we're flatter than a fritter. We are absolutely not gaining and not losing ground in hospitalizations, deaths, and new case development. But we cannot blink on this because Michigan is falling apart at the seams. Other countries around the world are falling apart at the seams. And the reason is because their case counts are getting worse. Okay. We've had a number of crises. I talked about the arc of a crisis. We remember, and I'm going to roll the tape back just for a minute because it's relevant to this discussion. Remember PPE, the protective equipment, masks, gowns, etc. That was a crisis 14 months ago. Testing, we didn't have the testing devices. We didn't have the testing reagents. We're in great shape with that now. Hospital beds. We never got overrun in the state. Sabato and Dr. K, I know, will tell me that they came very close to intensive care unit capacity being fully met, but we made it. And I think we're going to continue to be in great shape. I meet with the hospitals quite regularly and keep track of this. Staffing. We had staffing crunches, but over 90% of people are immunized in hospitals and health systems now, and we don't have staffing problems anymore because people aren't homesick with COVID-19 for the most part. Therapeutics, you've heard about the I'm pointing to my vein here, you can't see that. Monoclonal antibodies that you give through the vein to prevent people from getting overly sick. We're in pretty good shape on those. Kansas has been a leader, and we've taken from other states, the allocation from other states. And then finally, vaccine. Let me talk a couple minutes about vaccine, and then I'll turn it over to my colleagues. We've done a great job in Kansas. We had a data glitch early on, and our data wasn't being recorded, but we fixed that with a workaround. We've given 1.85 million doses. You know, when you consider that there's 3 million Kansans and only about 2.3 million are even eligible because the rest are kids or below the age of 16, 1.85, that's a rate of 63,000 per 100,000 people. That has us in the top echelon of the 55 states and territories that the CDC tracks. I just pulled this off the internet this afternoon, as a matter of fact. So we're very solidly performing and getting shots in arms, and we have over a million first doses that have been given, 1,000,078, and 690,000 second doses for full immunization. Where is our challenge? Our challenges are, excuse me, and with librarians you have to use correct English. With challenges are hard to reach populations. There are people that are shut in because of age or disabilities, and we are working with the local health, the 105 counties, to find the people that are hard to reach. There's a lot of skeptics out there, call them anti-vaxxers or call them vaccine hesitant. I think of those as a little different terms, by the way. But we must do what we can to get the people that are riding the fence, because there are some people saying, I'm going to take a wait and see attitude, and I want to make sure that we can win over those people, because these are spectacularly successful vaccines. And by the way, I might comment on Operation Warp Speed. You heard that, that's the White House. Started during the Trump administration and is continued in the Biden administration. General Perna and I, he runs it, all right, on a first name basis now. The warp speed occurred in the production and the distribution of the products, not the research. This has gone on since 2003 with SARS. So the research that has led to these spectacularly successful vaccines is not warp speed, but the production and distribution is. There's people that are culturally disinclined to get this for a variety of reasons, and there's racial and ethnic differences in terms of the willingness to get the vaccines. I'm going to close my comments by saying we have all four of the variants of concern. We've got I won't use numbers, I'll use names. UK variant, that's the United Kingdom variant, South African variant, Brazilian variant, and the California variant. We have all four of those in the state of Kansas. I think that the vaccines are protecting well. I've got some case studies that would make your head spin. If we get to it, I might get a moment, I might tell you a couple of them later. But the vaccines, I don't know if they're perfect for those variants or not, but we know that they're very successful for them, at least for preventing hospitalization and death, which is a pretty good place to start. We have all four of those variants in the state. And again, very pleased with the results we've seen with them so far. We have a lot of testing available. It's free. It'll be free through the end of the calendar year. We now are at a fairly low percent positive. 2.9% of the tests being run in the state of Kansas right now are positive for COVID-19. You'll recall that we were back at 15 to 20, 25% in some situations in the not too distant past. So we're doing pretty well on the testing, but we cannot let our guard down. We have flattened out, and I think it's really important mass gatherings are still not to be advised. Wear masks when you're around people, then you don't, because I think it's still the safest way to go. And with that, Dr. Cicillo, I know, is going to talk about the methodology of the vaccines, and I will leave it to Dr. Cicillo to cover that. So with that, Ken, I'm going to turn it back to you, and then of course I'm going to go get that sun out of my eyes, but I'll be right back in a second here for the rest of the show.
Thank you, Dr. Norman. We're going to move to Dr. Katrapati right now. I know Dr. K has some PowerPoint slides that he would like to use in his opening statement to kind of explain things a little further. Dr. K, are you there?
Yes, I'm here. Can you hear me okay, Ken?
Yes, very good. Go ahead.
Wonderful. Hi, guys. Thanks, everybody, for the opportunity to speak with you all today. Truly an honor to be on this panel with Dr. Norman, Dr. Cicillo. Before I kind of talk a little bit about how coronavirus and this COVID pandemic has affected people with respect to their cardiovascular health, I want to really give a shout out to really every healthcare worker that's chipped in locally where I am, and obviously throughout the state and nationally. Without our nurses and technicians and respiratory therapists and everybody basically chipping in, the folks that clean the rooms, and obviously to our patients who've struggled enormously, and to their families. As Dr. Norman said, that the arc is flattened, and hopefully we can all come out to the other side where we're doing okay. As many of you know, one of the first cases in Kansas was at our hospital, Providence Medical Center. The patient unfortunately had a poor outcome, and we've learned a lot from that very first patient to where we are now. And I was I was tasked to talk a little bit about cardiovascular effects of coronavirus. So let me just do that here a little bit. I'm going to put up share my screen here in just a moment. Can you guys see that okay, hopefully? Perfect. Again, I'm Dr. Katrapati. I'm privileged to work here locally in Providence and in St. John. So, this whole concept of the viruses affecting the heart has been around for quite some time. As Dr. Norman mentioned, the coronaviruses, the influenza viruses have caused difficulty with folks for many decades. Specifically, we know that these viruses can affect the heart directly, and they can also affect the heart indirectly. So just to give you an idea, HIV has had effects on the heart. Things like Epstein-Barr virus, mononucleosis or hepatitis C, all these things have had effects on the heart. So the question is, how is this caused, and what can we do to prevent it or treat it, really? So just to give you a quick idea about the pathology, this is the kind of the spike protein and the picture of the SARS virus that you guys have all seen in the news. This virus it can affect the body in so many different ways. It can obviously affect the lungs and cause infection. It can cause inflammation in the body. And these infections and inflammation in the body can ultimately lead to damage to the heart muscle, what we call cardiomyopathy, kind of what I said in my opening slide, the viral cardiomyopathy. When we talk about a heart attack happening for folks, we know that there are several different types of heart attack. For most of us, that are not in medicine, when people think about a heart attack, they think about it as a blockage to one of the blood vessels in the heart, leading to some heart damage. Whereas when we talk about viral cardiomyopathy or viral myocarditis, which is inflammation of the heart muscle, it's usually related to the virus either directly infecting the heart cells itself, or the virus basically causing a inflammation throughout the body. So this, as the virus enters your body recognizes it and creates this inflammatory response, which is part of the reason why we've had such a terrible time with coronavirus. We've realized that over the last several months that this inflammatory cascade, these release of these enzymes throughout the body that leads to a lot of the damage that we see. And we know that the coronavirus gets into our system through these specialized cells called ACE inhibitor or ACE2 cells in the body, and they're prevalent all across the lungs, the heart, the kidneys, the intestines, and so these virus particles are directly infecting the heart or the body through that mechanism, and also with the response that we see. And so the kind of this two-pronged effect that these viruses are having on our body. Some of the symptoms we've seen for folks that have presented to us with this coronavirus, basically the things like chest pain, shortness of breath, palpitations, fatigue. People have passed out, and on extremes of end, we've had people who presented with heart failure. I can actually think of a woman who was in her 50s who had a coronavirus probably back in the fall of 2020, and over the last 3 to 4 months, unfortunately, has had worsening heart failure, where she ended up actually getting a heart transplant at KU because of the coronavirus. And I bring that out just not to scare people, but to say that this is a very serious thing. This is a very serious virus that can have serious consequences to even some of the healthy folks. But luckily, what we've seen throughout the data over the last several months is that that's a very rare instance. The majority of the folks that have coronavirus do very well. People ask me, how many people have heart issues, et cetera. I will say that of the folks that recover well and do okay, which is the majority of us, thank God, most of those folks do not have any issues. I've seen several folks in my office who've had coronavirus, who've recovered. Their heart muscles look fine. They don't really have any issues with their heart rhythm, et cetera. But those folks that have been admitted to the ICU, who've been maybe on a ventilator and survived, about anywhere between 10 to 30% of them have had some long-term effects, ranging from a heart attack or weakness of the heart muscle to heart rhythm problems that have required intervention of some sort. And as we've learned about the pathophysiology or how this virus causes folks to have heart issues, we've been able to address it as more aggressively over the last several months. Just to give you as an idea, what have we done, for all my patients who've had coronavirus, who do have persistent symptoms. So I'm talking about those folks who, if you're one of those folks or your family members or colleagues, please do ask them to consider being evaluated if they have persistent symptoms, if they're still short of breath, if they're still fatigued, if they're still having some sort of chest discomfort. It would be important to go seek medical attention, and their doctor might order specific tests such as heart monitors or ultrasounds of their heart, or MRIs. When it comes to things like MRIs, I remember back when the fall sports were kind of canceled, college athletes and others were kind of upset because there was this concern that coronavirus could affect, young athletes and their heart. And I think that was kind of overblown by the media. Really, we have not seen a preponderance of what we call myocarditis or inflammation related to coronavirus in younger athletes, but certainly we do urge that everybody be careful. As far as the general population, does everybody need all these fancy tests? Absolutely not. It's again those folks that are truly symptomatic after a bout of coronavirus. We do have some new, heart-specific treatments. We've kind of focused on this anti-inflammatory things. When your joint hurts, you might take an ibuprofen. It's kind of the same way where there's inflammation inside the body. For those folks that are not very sick, meaning the folks that are not in the ICU or on a ventilator, we have been able to use things such as non-steroidal anti-inflammatory drugs or steroid drugs to kind of help with this inflammation that we might see. And there are some other drugs that affect the pathways of inflammation that we've also been able to use. Again, I will be the first one to admit, as I have before when I've done a couple of these online forums, that nobody really is an expert in coronavirus. If anybody tells you that they're the world's #1 expert in coronavirus, please run away from them, because we're all learning together as we go through this. And I think, Sabato and I kind of have this conversation all the time. When you look back over the last year and a half, I can maybe point to maybe 1 or 2 things that we've done differently, yet we've had a drastic change in terms of how much death and destruction there has been. So I'd be curious to hear Dr. Norman and Dr. Cicillo's thoughts on this once we get to the discussion point. So we don't quite know everything about this virus, but we do know that it can affect the heart. It can cause long-term damage, but thankfully at this point, it's very minimal. This is kind of my last slide here. I have people always ask me, hey, should I get the vaccine? Because I've heard of there are all these side effects that are known. And the honest truth is, yes, none of us knows what's going to happen 10 years from now if you get the vaccine. But as Dr. Norman said, this technology has been around for more than a decade. They're actually going to think about using this technology for the Zika virus. If you guys remember when that happened about 4 or 5 years ago, they were thinking about using that. There just wasn't a big need for it back then, so it didn't come through. But at this point, from the available scientific evidence, and I have to be a scientist when I say this, because everybody wonders, what's going to happen in the future. And I say that, so far there has been no clear-cut scientific evidence to support any heart or vascular damage related to the vaccine itself. It is truly a miracle of modern medicine, to be honest, about this vaccine. And, I tell patients every day, that I ask them, my first question or my last question at the end of the visit nowadays is, have you gotten your vaccine? And if they haven't been able to get the vaccine, we kind of talk about, what are the reasons why they haven't gotten the vaccine. And we kind of try to discuss some things. But the long story short, from my experience, what I've seen in the hospital, I've been privileged to take care of a lot of these patients, and now we're able to at least help them and get home for a lot of them, which we couldn't at the very beginning. The majority of COVID patients or folks that get infected with coronavirus do not have any long-term complications, which is good. But if you are having persistent symptoms, it would be important to seek further medical attention, not to be alarmed, but just to make sure that there has been any long-term damage to the heart muscle. And at this point, the currently available evidence, really does not suggest any heart related side effects from the vaccines, and that the best way to protect yourself really is to get vaccinated with whatever vaccine there is available to us all. I just wanted to say a couple other things. Folks have mentioned that, we're trying to get over this hurdle. I will say we cannot let up at this point, because I have personal experience with family in India at this time. Actually, they are absolutely struggling in India. They're able to get over that first wave or second wave, and now they're maybe in their third wave. There is really a lack of adequate hospital beds and oxygen cylinders. Really, people can't even get oxygen. They've been getting sent home, and this is personal, family, friends that I've been able to speak with and talk to. So hopefully, we can all pass on the word that this fight is not over yet, and we can hopefully get over this. So thank you so much, and I'll turn it over to Ken again.
All right. Thank you, Dr. K. Good information there. Okay, we have Dr. Cicillo now, who will say a few words as well. Doctor?
Well, thank you all for inviting me. This is definitely a privilege. I just wanted to talk a little bit about, as everyone knows, I'm a pulmonologist, so I do see some patients in the office that have persistent symptoms. And I'm sure that folks have heard the term long haulers or long COVID. So we do have a few, not many. Oh, and the other thing I want to do is echo the same sentiment that Dr. K had, Katrapati, is that whatever I say today is probably going to be incorrect, or at least not totally correct 6 months from now. So as of today, what we know is that folks that if you ended up in the hospital with mild disease and you were in for, let's say, less than 2 weeks, 5 to 14 days, more than likely you will recover with no symptoms and do well within, I would say, anywhere between 2 to 4 weeks. But if you were in the hospital with severe disease, especially in the intensive care unit, it may take months. So everybody should understand that severe disease, you may have symptoms of fatigue and shortness of breath ongoing for up to 6 months. But with that being said, we do get patients in the office that come in, and the common persistent symptoms, number one is fatigue most of the time. The second one would be shortness of breath. Third is chest pain, and last is cough. So if a patient comes to me, obviously I interview them, examine them, and I do a complete workup, including pulmonary function tests. So the pulmonary function test is a breathing test. If folks haven't had experience where you sit in a box, you take a deep breath, and you blow out, those numbers help me identify those patients that have numbers that are very similar to asthma. So if you're all of a sudden your bronchial tubes or your small bronchial tubes deep down in the lungs become hyperactive, you become short of air when you exert yourself, or you may have a cough. And there's a simple fix with that. We provide bronchodilators, the inhalers, the puffers. Second test that I normally would obtain would be a CAT scan of the chest. And that's to rule out, as people have heard on TV, on media, that the SARS-CoV-2, the infection or just the virus itself, could cause the body to form blood clots. So we look for blood clots in the blood vessels of the lungs. At the same time, the CAT scan allows me to look at the lung parenchyma, the meat of the lung itself, because the virus and the disease could cause scar tissue formation. And I've taken care of quite a few patients. And there's one patient that stands out in my mind that ended up with severe scar tissue formation as a result of having COVID-19. And this patient was in the hospital for well over 2 months. And there's a few patients that will have a little bit of scar tissue formation within the lungs that may last up to 6 months, but eventually it goes away. So very, very few patients end up with some scarring that does not go away. And lastly, we do what's called a 6-minute walk. We have the patient walk up and down in the hallway, basically to give me an idea if they truly are short of air with exertion. At the same time, we check their oxygen level and provide oxygen if needed. Lastly, after all of that is done, if everything checks out, I typically I try not to give the perception to the patient that, hey, there's absolutely nothing wrong with you, it's all in your mind. That's not true, because we really don't know. There could be maybe a little muscle metabolism disorder. So in order to really find out if there's a problem with the muscle metabolism, you would have to do a muscle biopsy. Obviously, we're not going to do a muscle biopsy at this time. So what I try to do is reassure the patient that with time, things will get better. If they have not seen a cardiologist, I will refer them to the cardiologist to make sure that the heart muscle has not been damaged. Otherwise, I have them come back and try to reassure them that things will eventually get better. So that's, from a pulmonary standpoint of view, that's what we're dealing with. But luckily, it's not very few and far in between where patients have persistent symptoms for a long period of time. I do want to say a little bit about vaccines, because I am a little bit disheartened at times. I get patients in the office, just like Dr. Katrapati was saying. My main question, probably at the very beginning, is I use the word, have you had the opportunity to get vaccinated? And some folks say no, and then I try to dig in. And there are folks that are still hesitant. So, there's this idea that the virus gets into our own DNA. Well, that's not true. I was sitting here trying to think, what kind of an example can I give to make folks understand how this works? Well, how does this work? The vaccine is basically made up of the spike protein, that little spike protein, the halo that's around the virus itself. A portion of that is a protein that is injected into our arm, that travels throughout the body, enters the cell. When it enters the cell, it basically uses the cell machinery to replicate itself. Once it replicates itself, it causes a further reaction, and the body looks at that and says, well, this is foreign, it's not supposed to be here. So it makes antibodies. It makes antibodies to kill off that protein, that foreign protein that entered into our body. Then, God forbid, down the line, you are infected with the virus. The body says, oh, I've seen that. You don't belong here. So those antibodies attack the virus and kill the virus. And that's how we get protected from getting a severe infection. So it's sort of like it does not enter the nucleus and doesn't bother. There's no way that it could possibly interfere with our own DNA. So it's not going to change anything whatsoever within our cells. It's sort of like, I was thinking, I'm looking around, I looked at the kitchen. It would be very similar to someone coming over my house and saying, okay, I'm going to use your kitchen to make some spaghetti and meatballs. They leave. They don't take over the whole house. That's basically the concept how these vaccines work. So the Moderna and the Pfizer vaccine uses a lipid nanoparticle. So that spike protein is placed in this lipid nanoparticle. It's injected in the arm, and it then goes throughout the body and enters the cell. So there's talk about chips being implanted in us. It's impossible. Everybody have seen it. You have a liquid solution that there are so many units within a vial that's injected in the arm. So that the Moderna and Pfizer work by the lipid, that fat particle carries the messenger RNA, which is that spike protein throughout the body. Now the other vaccines, the AstraZeneca and the Johnson, they use the carrier there is another virus. So they put in the messenger RNA within that virus. It travels throughout the body, enters the cell, and it produces antibody formation, just like the Moderna and Pfizer. And these vaccines are very, very safe. Yes, I know there's been some talk lately about the Johnson & Johnson has been paused because there's been 6 out of 6 patients that received it, or 6 folks that received the vaccine ended up with blood clots. But if you do the math, 6 out of 7,000 and change, that is a very, very small percent. And so there's obviously risks and benefits to everything we do. Is it related? We don't know. I applaud CDC and the FDA for pausing and saying, let's look at this more closely before we continue utilizing the vaccine. So I always present to my patients, I always say, look, the glass is half full. In this case, I think we should applaud the FDA and the CDC for saying, let's pause, let's look at this more closely before we continue using the vaccine. And that should reassure the public that there is a safety net and a safety mechanism for everything we do. So you have to trust the science. You have to have some faith in us and the medical community. With that being said, we'll probably leave it up to I believe there's going to be a Q&A. Mm-hmm.
Yes. Thank you, Dr. Cicillo. And I think it's important, and you mentioned this, it's important to note that we're having this event on April 21st, 2021. I think Dr. Norman brought it up too. 6 months from now, a lot of this information can shift, change. I mean, this is a point in time and we're having this discussion. We have received some questions both before the event started and during the event, seem very focused on the vaccines. As you mentioned, you can't look at an information source without hearing something about the Johnson & Johnson vaccine. Let's talk about the differences between, personally, I got the Moderna vaccine. Pfizer's been available in the area, some Johnson & Johnson in the area. Dr. Cicillo, you're on the screen now. Let's start with you. Talk about the differences, and you did this a little bit, but talk about the differences between the vaccines.
Okay, the only difference, well, there's two major differences. The Moderna and Pfizer vaccine utilize what's called a lipid nanoparticle as a transport mechanism, versus the Johnson & Johnson and AstraZeneca actually utilize the adenovirus. Adenoviruses have been around forever. And in fact, I'm glad Dr. Norman brought this up. People think that, this process of making vaccines, we went way too, and I've heard this once in my office, a patient said, well, I don't trust it because they did this way too fast. Well, and the science has been ongoing since 2002 during the first SARS infection, SARS Middle Eastern SARS outbreak there. So the science was there. The only thing that was sped up was once they went through, so they don't, let me go through this a little bit. Vaccines are developed in a way, the mechanism that a vaccine is developed, they first start with making sure that the vaccine is safe. So they do these preclinical trials. Before they even attempt at giving vaccines to humans, they test them on animals. They give the vaccine to the animals and they look for two things. Number one is they look for side effects, making sure that there's no major side effects. Number two, they then look at the efficacy. Is the vaccine producing the antibodies that we want the vaccine to produce so that if you get exposed to the virus, you could fight it off? If the answer to those two questions, and this is preclinical, before they even get tested on human beings, is yes, then what they finally do, they take the virus and inject the virus into the animal. In this case would be mice. These would be mice that were given the vaccine, and then after they allow for the antibodies to be formed, they actually give them the virus, and then they say, well, is the vaccine effective against the mice? And if the answer to all those three is yes, then they move into phase 1 trial. This is when humans get involved. In phase 1, they normally tested no more than 100 participants, okay? Because obviously if things go wrong, they don't want a lot of people to get ill. And during those times, doing phase 1, they take about 100 patients, use healthy volunteers. These are all healthy volunteers. No one has any comorbidities. And they proceed with injecting these participants with the vaccines, and they monitor, once again, side effects is number one. And lastly, what they try to do is provide a low dosage of the vaccine and a high dosage. So in phase 1, they basically look for side effects and how much of the vaccine should we be giving. And they only use about 100 folks. If that goes well, they move on to phase 2. Phase 2, they usually use about 100 to 1,000 participants. And this time, what they attempt to do is use not everyone within that participants are healthy. They match the demographics of the population. So they start testing the vaccine on everyone, folks that are young, folks that are elderly, and folks that have illnesses, comorbidities. And then once again, look for side effects and efficacy. Once that's completed, so for instance, I think, and maybe Dr. Norman, you could weigh in on this, what happened once they got through phase 1 and phase 2 and things were going well, this is when the US government came in and said, let's start mass producing this vaccine because I think it's going to work before we complete phase 3. So they started mass producing the vaccine. Now, if it didn't work in phase 3 and the FDA did not approve the vaccine, we would have been stuck with basically vaccines that were useless. So the process, the science was not sped up. Everything else past the science was sped up. And then in phase 3 in trials, they used large population, and they give it to well over, well, probably, if I remember correctly, the Moderna and Pfizer vaccine, Moderna was given to, how many thousands of people now? I can't, oh, here it is. Yeah, the Moderna was, no, the Pfizer was given to 43,000 folks in phase 3 trials. And they looked for, in the phase 3 trial, they gave it to 43,000 folks, and half of those folks received the placebo, so they did not receive the vaccine, and half received the vaccine. And the efficacy was at 95% effective, and in being effective in preventing mild disease, and it was 87% effective in preventing severe disease. That's the Pfizer. So, I mean, they tested well over, once they get through phase 1 and 2, you're talking about 30, 40, 50,000 patients that are being tested before they roll it out to the general public. So hopefully that cleared up a few items.
Thank you. Thank you. I do want to move on to some additional topics, but you did ask Dr. Norman if he had anything to add, and Dr. K, if you have anything to add on this topic as well, and then I would like to move along. Dr. Norman?
Just to add quickly, thank you, Sabato, for that excellent summary. You know, we've got over 1.8 million doses in Kansas, and we're approaching 200 million in the United States. So you talk about a clinical trial, we've got a lot of people that have been vaccinated, and it's going very well. We have a system called the Vaccine Adverse Effect Reporting System, VAERS, where we monitor, it's a CDC program that monitors side effects and complications. And it's all been reassuring. The exception is these, as pointed out, these 6 cases of this J&J, Johnson & Johnson product, but the safety profile of the Pfizer and Moderna have been spectacular. They're more alike than different. J&J, as Dr. Cicillo pointed out, is a little bit different, but I think it'll be back, and I'd be happy to comment on that later as to what the tea leaves say will happen to the Johnson & Johnson. It's an advantage because it's a 1-dose vaccine, but all 3 of them have very good safety profiles.
Dr. K, did you want to add anything?
Yeah, just a couple things. I think the biggest thing that I always tell my patients is, no medicine is perfect, whether I'm giving them a heart medicine or a vaccine. Nothing is perfect at preventing, all of the bad outcomes. But I think what has been spectacular about these vaccines is the fact that they prevent the thing that most of us care about, which is, being in the hospital because of a very bad infection or dying from the virus itself. Yes, you may still get the virus, and you hear in the CNN or Fox News about how there are breakthroughs and all this other stuff. That does not mean that the vaccine did not work. The main goal of this vaccine is to make it just like any other cold virus, right? We're hoping that that's what's going to happen down the road in 2, 3, 4 years, that this is just like a run-of-the-mill common cold, and people move on and do okay. And the other thing I think about side effects and monitoring is, the fact that we were able to even monitor the Johnson & Johnson vaccine and figure out that, 6 out of almost 7 million people, I mean, somebody is keeping track of this so darn well that they were even able to find 1 in a million person that had this side effect and keep an eye on it. I would look at it as not a bad thing that the Johnson & Johnson vaccine was put on hold. I'd actually look at it as a good thing that they were even able to find such minute, numbers of side effects. So I would say that, to Dr. Norman and all the healthcare folks that worked in the government, I mean, this is a fantastic feat, right? To be able to find such a short or small number of people that have had side effects.
All right. Thank you, Dr. K. One of the questions we received earlier, and I know this is, to me, one of the scarier propositions as we move forward, are the variants, the mutations. Dr. Norman, I'm going to start with you because you're the chief health officer for the state. What's Kansas seeing in terms of these variants? And then I'd like you all to comment on how do we combat this? I know that the current vaccines are effective somewhat, especially at preventing major sickness and death. But let's start with you, Dr. Norman. What's Kansas facing in terms of these variants?
Let me make sure I'm unmuted. Yes, we have not seen the high preponderance of the variants yet, but we will. Michigan, the UK variant has become the predominant strain already in Michigan, which, although Michigan is a state that they do not do a lot of the anti-contagion measures that we talked about, meaning masks and social distancing and the like. They're a rather non-compliant state from that perspective. But let me say something about the variants. One is we're doing a lot of testing, and what's called whole genomic sequencing. And think of it as Ancestry.com comes to viruses. We can learn what the makeup of the virus is. And let me give you a great example that wraps a lot of this together. I teased you with it about 25 minutes ago, but now I'm going to tell you. Just happened last week. A case study. This is fascinating. We got word of and knew of a staff worker in a skilled nursing facility, a nursing home, who was unvaccinated, who was ill, came to work, bad idea, but well, okay, got tested. Not only was this person positive for COVID-19, they had the P1 Brazilian variant, which is actually, I worry a little bit more about that than the other ones we've talked about so far. So, big red flags. The nursing home, for the most part, all the residents had been immunized, okay? But we brought in a strike team to do every 3-day testing of the people. There was 2 of the residents, both women, one 85 years old, one 95 years old. Both have been fully vaccinated, and both came up positive, not only for COVID-19, but the same P1, and it was a P1 variant. And when we compared that variant to the one that the staff person had, who was taking care of them, it was exactly the same variant. I mean, it's like a fingerprint or a thumbprint. You can get that specific about it. The remarkable thing is, and this goes to both of these guys' point earlier, neither of these women, age 85 and 95, were symptomatic. They weren't ill. They weren't hospitalized. They didn't die. And that is a dramatic success, that they could become colonized or infected with it, call it what you will, but they did not become ill with it because they'd been immunized. And that is a dramatic success, because both of these guys I know will tell you they've been taking care of a lot. The nursing homes were the hottest of the hot spots, and that population, and they would not have done well. So dramatic success. We are seeing a lot of the variants. We're going to continue to see a lot of the variants. I think that the UK variant will become a dominant strain, but I think as long as we get vaccinated and do the anti-contagion things until we're out of the woods, I think we're going to be fine.
Dr. Cicillo, did you want to add anything?
No, I don't have anything to add. I think that from what I've heard and read so far, the science shows that there is definitely a benefit to getting vaccinated, and it seems like the vaccines are working against the variant. Yes.
Dr. K?
I was going to ask Dr. Norman, over the last year or so, a lot of the things that people thought were going to be effective, like remdesivir or the immunoglobulins, et cetera, that we've talked about, have not really been so effective as the vaccines have been. Some people might say, hey, I'm not going to get the vaccine. I'm going to get something else like the infusions that people that we have available now. You have the kind of the pulse nationally. What do you think has been effective besides the vaccine? Can you really pinpoint to anything, like steroids or these antibody infusions that may have really made a dent? Because I feel like I haven't really seen, taking care of patients in the ICU, I've not really seen a big dent made by these other kind of therapies. It's been mostly the fact that we vaccinated people.
Yeah, Dr. K, I agree with you. I do think that there's indication that the pre-hospital phase, if a person is very early on given the bamlanivimab or one of those other monoclonal antibody cocktails, I think it does reduce the risk or the incidence of hospitalization. But there has not been a magic bullet. It is, and I think will continue for quite some time, be the vaccine. There's all sorts of therapeutics in the pipeline, but they have just not emerged yet, and we're still early on in the development of those therapeutics. So I agree with you, Dr. K.
Okay. let's go ahead and move on. Kind of a two-part question here. It has to do with suggestions, and we're getting away from the medical and maybe a little bit towards the political, but how can we educate and increase the number of Kansans who are going to opt in and receive the vaccine, and maybe add to that a little bit about herd immunity and what we've heard about herd immunity. And Dr. K, let's start with you on that, if you don't mind.
Sure, no problem. I think a lot of this is driven by fear and not knowing. I think the way out of any situation, I think, is education. I look at this as when my patient comes into the office and they might have a heart problem and they're fearful. They don't want a specific test or they don't want to take a specific medicine. And we just have to sit there and talk about it and go through the risks and benefits. I think there has been a lot of misinformation. I mean, I wish I could shut down Facebook for about a couple of years because I've had patients, who are educated, who are very well educated. These are not folks that don't know anything about science, or the stereotypes, but at the end of the day, they're educated folks that come to me and say, well, I heard that the vaccine will make you impotent, or the vaccine will prevent pregnancy, or those kinds of side effects. And we just sit there and talk about it. And I really do think education is the way out of this. And hopefully forums like this will continue to spread the word. And as I said, every patient, just like I asked them, hey, how you doing? Are you taking your medicines? We have a conversation about the vaccine. And I think that's the only way out of this from my standpoint.
We had a question come in during the chat. Interesting, we all get that card when we get our first shot, or in the case of J&J, our only shot. There are multiple lines after the first two shots. There are blank lines on the vaccine card. Are health practitioners anticipating that we will need regular boosters in the future? I'll start with Dr. Norman on that one.
I think it's highly likely that will be the case. When you think about the influenza shot you got this year, I'm assuming you all got the influenza shot this year. We had almost no influenza this year. It was a dramatic, remarkable year, you might add. But you get it's a quadrivalent. There's four different, two influenza A's and two influenza B's. It wouldn't surprise me a bit to see that whether that's in with the influenza ultimately or as a separate one, to have an annual, or I don't know, it could be even more often than annual booster, because as Dr. Cicillo was pointing out, we talked about the variants, it very well could be, and the mRNA vaccines are more easily modified. I think it's highly likely that there'll be boosters that will be necessary and will be desirable. I look at that as a good thing. I was stationed in the Middle East in 2017 and 2018 for a good part of the year. And Sabato mentioned the Middle East respiratory syndrome, which is a highly lethal coronavirus, different than COVID-19. And they didn't have a vaccine there, and it's still grinding along. And so I open up my arms and say, bring on the boosters, and it would be nice to build it into our rhythm of our life, so we can get our influenza and our COVID-21. I don't know what the numbers will eventually be, but I think it's going to be with us as an endemic illness for a very long time, probably the remainder of our lifetimes. And I'm hoping that we can drive it into to a period of quiescence through ongoing booster doses.
Dr. Cicillo, did you want to add something?
No, I totally agree. We will definitely need a booster. This is going to be a yearly vaccine endeavor, because so far the science shows that these antibodies last anywhere between 6 to 8 months. So
does it appear promising that if we are going to move to needing booster shots for COVID, that it could be combined with the flu shot, so that I only have to make one trip to my doctor once a year to get that shot?
I don't have the knowledge to answer that. I'm not a virologist. Yeah.
And anybody else want to take a swing?
I don't think that can be known yet, Ken. It would depend on FDA approval, and it would have to be tested in a combination like that. I think that will be the ultimate goal, because it would increase the uptake by people if they can be made easy. One of the things I've learned long ago is it's easier for people to do the right thing if it's easy, whatever the therapy, if it's easy. And I'd like to make it as easy as possible for people to do what I think is the right thing.
I know we were only scheduled to run for an hour, but all three of our guests have agreed graciously to go a little bit longer. We do have questions coming in. Here's one that I've heard in the Lansing community. Somebody has just asked it a few minutes ago. If a person has already been infected and recovered, why would they need a vaccine? Hasn't the body already built up immunity?
So I guess I can answer that question from personal experience. I actually had the coronavirus about 3 days after my first dose of the vaccine. So again, this is not because the vaccine failed. It's just, as you guys know or might have heard in the news, the vaccine takes about a full 2 to 4 weeks to get up to speed and get effective for your body to make the antibodies. And the way I would answer that question is this: we anticipate needing booster shots. So that basically, if you've already had the coronavirus, you've made some antibodies, think about the vaccine as maybe your booster to give you a little bit more strength and immunity against a future exposure. So I unfortunately had it, knock on wood, I was able to get through it. But certainly I signed up, right away and got my second dose, and I would encourage other folks to do it if they've had the virus. But I would think about it as a booster shot.
Okay.
I have one comment, Ken, I'd like to make on that, and because it's about 2 weeks ago, the Journal of the American Medical Association, there was an article published that looked at exactly this question, which is what's referred to as neutralizing antibodies, the antibodies that neutralize the virus. And it compared people with only naturally occurring infection that Dr. K mentioned versus people that had been immunized. And there was a 10 times higher level of the neutralizing antibodies circulating in the people that were vaccinated versus the people that had only the naturally occurring illness. Now, there's other kinds of immunity other than antibodies. We won't go into it, but that's an indicator that it's probably a more effective way to get better quote unquote immunity by going through the vaccination route. So the bottom line is people get infected with the naturally occurring virus should still get vaccinated if they haven't been.
Okay. An issue that has come up more and more recently as schools have opened back up, and now everybody, I believe 16 and older, maybe it's 18 and older, is eligible to get the shot. What about vaccinating children? What do we need to find out more? Are there clinical tests still going on? Do we vaccinate children? I think we have to at some point, right?
I'll take a whack at that if you'd like me to. The Pfizer is approved for 16-year-olds and older, and we're starting to work with superintendents from schools to have vaccination clinics for 16-year-olds and older. As a matter of fact, they're bringing in their parents, they're bringing in their grandmas and others along with, and make it kind of a family event in and around the schools, which is a good idea. Our own Children's Mercy Hospital right here in Kansas City, Missouri, is the lead research entity that's looking at a pediatric clinical trial right now. There's nothing approved for anything younger than age 16. Pfizer has put in for FDA approval for, I think it's, I don't know, maybe one of you guys know, 11 or 12 to 16-year-olds. I do think, kids get the illness. We've had kids as young as 6 die of COVID-19 in Kansas. Kids, I think, ultimately will be vaccinated for COVID. But it's too soon to call what that approval process, what the research will show, what the safety profile, et cetera. But kids, we know, get sick, they die, and especially they transmit. We know they transmit the virus very effectively, which is bad.
Dr. Cicillo, do you want to add?
No, I agree with Dr. Norman that, well, up until now, we have not studied anything in kids, and obviously nothing's going to be approved unless it's studied, and there are ongoing studies. Yes. Yes.
Dr. K?
And I do want to add, I just recalled regarding getting vaccinated post-COVID. I totally forgot. That was great that Dr. Norman brought that up, that they did look at individuals that had the antibody levels with the natural infection versus the vaccine, and the vaccine was higher. So I would strongly recommend folks that have had the COVID to go ahead and get vaccinated. Yeah.
Dr. K?
I have nothing else to add. I agree with everybody.
Okay, great. Did want to ask about an oral vaccine. Is that in clinical trials currently? Is that something we can expect in the future?
I'm not aware of anything, Dr. Norman.
I have not heard it. I have not heard that to be the case.
Yeah, me neither.
Okay, all right. I did get a question come in asking to further explain the physiological process of how the virus, the COVID virus, attaches to ACE inhibitors within the body. Do you know of any other diseases that infect the body in a similar way? I know SARS was mentioned earlier, but I'll throw that out. Dr. K, you're on the screen now. Why don't you take a swing at it?
Sure. I'll just see if I can share my screen again. I had this slide earlier just to show everybody. There are enzymes in the body that regulate blood pressure and inflammation and everything else in between. And if you guys can see this, okay, there's something called the angiotensin converting enzyme where there's it basically changes one enzyme to a different enzyme. And then there's specifically what we call the ACE2 enzyme or receptor. That's kind of where the SARS-CoV virus attaches. And that kind of helps regulate, as you can see, this back and forth, the yin and yang, so to speak, of vasoconstriction, inflammation versus vasorelaxation. So some of these things help relax blood vessels and decrease inflammation. Some of these things increase the tone of the blood vessels or vasoconstrict them as cause inflammation. Our body needs to be able to do both. We need to vasoconstrict or make the blood vessels tighter to increase blood pressure or fight off an infection to cause inflammation. On the other hand, we also need to be able to relax blood vessels. And it's when this process gets out of whack because of this infection from the virus particles on this angiotensin converting enzyme, there's more of this vasoconstriction and inflammation happening. So that's kind of what the actual virus does. Are there other viruses out there that specifically attach this way? And not that I know of, and not that we've seen clinically being effective. So,
anybody else want to add to that?
Well, I think the simple way of thinking about this is that the virus attaches to this ACE receptor in the lung. And once that happens, there's a cascade of what they call cytokines being released. So proteins that are released that then produce further release of chemicals, and these chemicals basically destroy the alveoli, where we're supposed to have air. So once the alveoli get destroyed, instead of having just air within the air sac, we then start having fluid that accumulates within the air sac, and we have fluid that accumulates in between the alveoli. And so ultimately the patient becomes short of air because they're not able to exchange to get the oxygen out of the air sac into the bloodstream. And then it just causes havoc and basically destroys the normal architecture of the lung, and the lungs can't do what they're supposed to be doing. And that's how the patients end up initially on oxygen, eventually on life support.
Okay, I've got two more questions if you guys can stick around a little bit longer. The first has to do with research and predicting long-term effects. And I know we've touched on this a little bit. I know I'm getting ready to go for my shingle shot. I'm at that age, gonna go get Shingrix, 2-part shot. Talk about the potential for long-term effects of the new virus to where you'd have a post-polio syndrome, something along those lines. And maybe it's too early to really say much about that, but I wanted to throw that out there.
I'll take a shot at that. I've looked into this. I think the best answer right now is way too early. We're only a year and a half into this pandemic. I think that we will have answers, some good answers probably 5 years from now, 10 years from now, because it's too early, to say. So.
Okay. Did want to, and I'm going to direct this to Dr. Norman. You mentioned spending time in the Middle East a couple of years ago. As you followed the way this COVID-19 pandemic has been battled in different countries around the world, what have you seen as maybe best practices? And I'll throw this out to all of you. How have other countries done it where maybe the US can learn a thing or two?
We've done about the best of any country, and maybe with the exception of Israel, in terms of vaccine rollout. But then again, Israel has the same population as Missouri, so it's a little bit apples and oranges. There was a great study on the 8th of June in 2019 in Nature magazine that looked at why do some countries succeed more in this pandemic, and looked at 6 different countries, the U.S. being one of them, some Asian countries, and Salvatore's home country of Italy, and really what was found was that we didn't, because we've had a lot of disease in this country. The 2 indicators, the 2 predictors were, one, countries that had strong central influence by the government that had a profound influence on people's anti-contagion behaviors, meaning masks and social gatherings and the like. And the second one is fascinating. Now we're getting in the realm of social psychology, I think anyway, and that is that the countries that did the best were the ones that said, that basically looked at individual liberties versus collectivism and saying, I'll take one for the team in order to push down the number of cases. And the Asian countries were the best in that, saying we're in this together. And in the United States, we're a bunch of hard-headed individualists that said, individual freedoms trump everything. And I'm not, and there's no political statement here. I'm just saying that that's what the indication was from this particular article. And I think there's something to that. The vaccine rollouts have been dramatically different state by state, and country by country. But that's going to be a game changer in terms of the countries and the states that do it the best. But a lot of the behaviors that people did, I think, had a lot to do early on with how rapidly or how slow the spread was contained.
Dr. K, you have family in India. You keep up with what's happening there.
Yeah. Yes. I think in India, it's a whole different problem. It is just, a sheer numbers game, right? We have about 300 million people here in this country, and in India, there's, well over 1 billion people in a square area that's half the size of this country. So I think they're struggling with the numbers problem, and certainly the infrastructure is not the same. I do want to make a comment about personal liberties. Again, this is not to be a political comment, but I am all for people doing what they want to, and I don't think there's, people live in this country because we all have rights. But I kind of look at this as, the seatbelt problem versus, public health problem. If you want to drive your car and not wear your seatbelt, and you crash your car and then something bad happens to you, that's your problem, right? But unfortunately, this coronavirus is not just your problem. I mean, if you don't wear a mask, you might be okay, but it might be your friend or your loved one that might be affected. So the public health is actually involved in this. So in that sense, I feel like it is our each and everybody's responsibility to do the best we can to help out the person next to us, our neighbor, our family member, et cetera. So I look at it that way. Yes, we all have choices, but hopefully we can all help each other out. And if you don't mind, Ken, there's a question on the chat about, what proof do we have that SARS-CoV-2 actually exists and has been isolated and purified per Cox postulate, so to speak. As you guys may know, there has been trials that are ongoing in Britain where they're actually going to infect people, that with the coronavirus that have been immunized to see if they're going to be protected. I'm not sure if they published their results yet, but I've heard of that. So Cox postulate basically says you've isolated a virus, you've infected, that causes specific symptoms, you've infected it into another healthy animal or person, and they have the same symptoms as the other person did, and then you can prove that, this virus exists. So we do know that this virus exists. There was some concern originally, and maybe Dr. Norman or Dr. Cicillo can point out about this, that, are we overdiagnosing coronavirus? Is this because of a laboratory, how many cycles of PCR are they running? And it's certainly that is not the case. We've done enough testing and scientific research on this that this is not because they're just isolating little proteins and calling it the virus. And maybe Dr. Norman, you can kind of chime in about what is the lab standard in Kansas and how many cycles is considered a positive virus, so to speak, because I think that was a big misconception at the very beginning, that we were all just kind of faking this and this was something that kind of was made up, and it's absolutely not. So.
Right, agree wholeheartedly, Dr. K. And by the way, we don't dial up or dial down the cycle thresholds. That is an FDA and manufacturer determined number. We're at 42 for a while, but when we went to a multiplex test that tested for influenza A, influenza B, and the COVID-19, that just became our standard test coming into the fall of last year. It put a cycle threshold at 38. But you know, this is I'm trying to be genteel about it. It's an argument that shouldn't be had anymore, really, because the COVID-19 virus is not a normal inhabitant in people's noses and in their bodies. It's not a normal organism. And if it's picked up at 24 or 28 or 32 or 38 or 42, which is the sensitivity, if you think of it that way in terms of the testing, it's positive. That question's been asked and answered 6 months or 8 months ago. But some people kind of want to keep dragging it out in order to discount the importance. And I think it's a distraction to even be having that kind of conversation. I understand the reason to ask the question, but it is a real disease, and to discount the disease on the basis of a laboratory test that is, well, I mean, we've done 3 million of those tests in Kansas alone. We're very familiar with this, and it's very valid.
Well, I appreciate everybody staying a little longer. I did want to give each of you a chance to maybe give a brief closing statement, maybe something we didn't cover or something you wanted to stress again. Dr. Cicillo, we'll start with you.
I think the take-home message from me personally, and I have 4 kids. I have one that's so strong-minded and anti-vaccine. And basically, I've told her, well, listen, why don't you do this? Get vaccinated for me, not so much for you, because God forbid you get the virus and pass it on to me or your grandmother, your grandfather, you're going to feel pretty bad. So everyone listening out there, if you don't want to get vaccinated for yourself, please do it for someone else you love.
Dr. K?
I think together we can come through this, as Dr. Norman pointed out at the very beginning. I will say, that we recommend the vaccine for many folks. There may be some folks out there that are either allergic or have had, serious allergic reactions to the vaccine in the past. Those folks should have a conversation with their physician and talk about the pros and cons. But for more than 90% or 95% of the folks out there, this is a very effective and safe vaccine. And I really honestly think that's the only way really out of this pandemic ultimately is hopefully, because that's the only thing that's been proven to help decrease the risk of complications. So.
All right, Dr. Norman, we're going to go ahead and close up shop after we hear from you.
Okay, well, I don't want to stand between people and their dinner or the next thing they do. Ditto with my colleagues said, and I think really it relates to an earlier question about how do we encourage the vaccine hesitant individuals to get vaccinated. And I think it's to educate, to have the voices out there of people they trust. We're going to be doing a lot of educating and marketing, and so that healthcare workers who are some of the most trusted individuals can do more and more to transmit that message, like my 2 physician colleagues here are doing it, and I thank them very much for that.
Well, a lot of the comments that are coming in right now are all thank yous for the 3 of you sharing your knowledge and sharing your time tonight and enlightening all of us a little bit more on what we're facing here in the last 13 or 14 months or so and what we're going to be facing in the future. So I want to also personally thank you for taking time out to enlighten us. Thank you.
Okay. Thank you all.
Thank you.
All right. That'll do it for tonight. We appreciate everybody that was able to join us, and hopefully you gained something from this presentation. Thank you and good night.